Hello everyone, Lauren Bean here. This is a lecture over chapter 22 of the respiratory system. The main function of the respiratory system is to move air in and out of the lungs to obtain oxygen gas and remove carbon dioxide waste. Those gases need to be obtained and removed due to a chemical reaction called cellular respiration, which occurs in our mitochondria. Remember that those organelles are the powerhouses of our cell. They're responsible for making ATP, right, usable chemical energy. So we obtain food in our diet, right? We obtain glucose, and glucose and oxygen gas are the starting materials for cellular respiration. In the mitochondria, a lot of different things occur in there, but energy is released from this chemical reaction, and we also produce some metabolic water and carbon dioxide waste. So we're always going to be taking in that oxygen, but also removing that CO2, that carbon dioxide, is just as important. Our respiratory system also functions in olfaction, so sense of taste, and speech. And here we can kind of summarize four main processes. So pulmonary ventilation, we're talking about the air just moving in and out. Inspiration, air going in. Expiration, exhaling, air moving out of the lungs. When we start to use the term respiration, that's when we're actually talking about the respiratory gases, oxygen and carbon dioxide. So external respiration, talking about the events that take place in the alveoli, the air sacs of the lungs. Oxygen diffuses from the lungs, the air within the lungs, to the blood. CO2 is going to diffuse from the blood to the lungs or out into the air within the lungs to remove that product. Then we have the transport of respiratory gases in our blood, right, due to our circulatory system. These gases remain dissolved within our blood. And then we have internal respiration, the exchange of CO2 and O2 between the blood and our tissue cells. So we'll go into more detail about these processes, but this kind of summarizes all the general stuff that takes place within our respiratory system. For major organs, we can divide this system into upper and lower respiratory tract or respiratory system. For the upper, we're thinking our nose, nasal cavity, paranasal sinuses, and the pharynx, the muscular tube at the back of our nose and throat. Then our larynx, our voice box, really serves as kind of the transitionary point to the lower respiratory tract. That gives rise to the trachea. Those branch into large bronchi. They get smaller, become bronchioles. And then we have the alveoli, the air sacs of the lungs, where that external respiration takes place. The nose is the only external portion of our respiratory system, and it provides an airway for respiration. Right, quite obvious there, but this becomes especially important when we consider newborn babies. They dominantly are nose breathers. So up till about 3 months, 4 months old, then the baby might start to utilize the mouth more for respiration. But those first early stages of development, they have to use their nose to breathe, because typically the mouth is going to be used for feeding, right, and for suckling. Of course, if the nose were to be plugged during that period of time, the mouth will become the airway, but dominantly, the nose is utilized for respiration. Other functions, the nose helps to warm the air, moisten it, filter, cleanse any debris in the air. So it really serves as an important filter as the air passes down into the lungs. It's a resonating chamber for speech. We all know that if we have a stuffy nose, our voice changes quite dramatically. And it houses olfactory receptors for our sense of smell. There's different regions, there's different components. I'm not really worried you focus a lot on the anatomy of the nose. It's just not very relevant for us. But do realize there are a lot of different features, and depending upon the pathway that you take in your career, you may need to learn more about this, but it's a little irrelevant. For the nasal cavity, we're considering all the internal features of the nose. It is separated from the oral cavity or the mouth due to the hard palate and the soft palate. The palatine process of the maxilla and the palatine bone form the hard palate, the roof of our mouth. And then we have softer tissue here forming the soft palate. The uvula being that little dangly thing at the back of our throat, that's just where that soft palate dangles down. When we swallow, the uvula makes contact with the back of the pharynx here, and it closes off the nasopharynx so that food and water doesn't creep up into the back of our nose. Sometimes that doesn't go as planned though, right? We've probably all experienced that really uncomfortable feeling when something creeps up into our nasopharynx. So within the nasal cavity, we have nasal concha, superior, middle, and inferior. These are bony processes, and they're covered in nasal mucosa. This really helps to increase that mucosal area. It creates kind of a convoluted pathway for air to travel through. So there's little canals or little meatuses. So as the air passes through the nose, it's warmed, it's filtered, right? It's even moistened. It really helps to cleanse that air before it makes its way down into the pharynx and leading to the trachea and our lungs. So very important processes within. The posterior nasal aperture is just this transitionary point between, the nasopharynx, the superior aspect of the pharynx, and these nasal concha, the most posterior aspect of our nasal cavity. An aperture just means an opening. The nasal septum is the wall that divides our left and right nostril or left and right nares. We have the perpendicular plate of the ethmoid bone, the vomer bone, and the septal cartilage here, which forms that wall. So you can see that most of, our nose is septal cartilage in the middle. We do have our nasal bones that rest atop and really give us our unique look and give us our unique nose structure. Toward the back of the nasal cavity, we see the nasopharynx, oropharynx, and laryngopharynx. So it is divided into 3 regions depending upon the area it's associated with, right? Naso-nose, oral, think oral cavity or mouth. And then at this point, we're getting to the larynx or the voice box. Utilizing the same image from earlier, we can illustrate a couple other features. The nostril just refers to the opening, the left and right opening of our nose. The nasal vestibule just being the cavity superior to that. So when you're picking your nose, you're really going up into that nasal vestibule. There's vibrissae or hairs within our nose that help to filter any real coarse particles, bugs or, bigger chunks of debris that may come in through the air. Most of the nasal cavity is lined with kind of standard mucous membrane, a lot of goblet cells, a lot of mucus production to trap any particles that come in. But the superior aspect of the nasal cavity has olfactory mucosa. Olfactory epithelium, very specialized and responsible for our sense of smell. We have olfactory sensory neurons that dangle down through this cribriform plate of the ethmoid bone. And we actually have neurons right here, always detecting our sense of smell. Here's a nice illustration that really shows the different areas of tissue. We have the olfactory mucosa in yellow that I was just talking about on the previous page. So we have that olfactory bulb, the olfactory neurons passed down through that cribriform plate. Blue representing respiratory mucosa, that's going to be continuous down into the nasopharynx. We see a transition at the oropharynx where we're swallowing, but once we get down to the trachea, that respiratory mucosa is present again. The respiratory mucosa is pseudostratified ciliated columnar epithelium. Remember those goblet cells, mucus production, cilia present there to help sweep the mucus and debris. We also see some NALT. That's just saying nasopharynx associated lymphoid tissue. So the region of some tonsils there, helping to stand guard against infection. And we have a variety of different glands in here, nasal glands, to creating a lot of mucus because this area is just subject to a lot of debris, right? And all the crap we take in the air. You'll see in green, we have mucosa over here as well, squamous mucosa. This is going to be a stratified region because, as we do pick our nose and this area is subject to abrasion, so we're going to have many layers of cells present in that anterior component of the nasal cavity. Paranasal sinuses are associated with our nasal cavity as well. These are mucus-lined, air-filled spaces really help to lighten the skull, warm, humidify the air, enhance the resonance of our speech. And just as the name implies, they're paranasal sinuses, right? They're to the side of the nasal cavity. They're like extensions of the nasal cavity, serving very similar functions. We have a pair of frontal sinuses. We have ethmoidal air cells with that ethmoid bone. We have a pair of maxillary sinuses and sphenoidal sinuses as well. So you can see a couple different views of that. Our nasal cavity and our paranasal sinuses become very evident to us when we have rhinitis. This is inflammation of those regions, right? It causes us to have a runny nose, watery eyes, sneezing, congestion, irritation of all of those regions. This could be due to either seasonal allergies, so some of you may be experiencing this right now, or different rhinoviruses can be the culprit as well. And those are responsible for just like the common cold that we may experience at least once a year. This can spread down. You can really start to irritate or infect the respiratory mucosa going down our throat. It could even lead into the bronchi and cause bronchitis. Right? So really the spread of this is going to determine the extent of irritation. But again, we really start to feel the irritation associated with those paranasal sinuses when you have pain, right in front in your forehead. That's because those frontal sinuses have become irritated. Or if you have pain on either side of your nose, more towards your cheek, right? Because you start to understand like, okay, those paranasal sinuses are really irritated. The best thing you can do for yourself at this point is to take an antihistamine to help to counteract that inflammation and reduce that swelling and irritation. So just want to talk a little bit more about the nasopharynx. This is lined with pseudostratified ciliated columnar epithelium. As I mentioned earlier, we do have the soft palate and the uvula here. When we swallow food and drink, that makes contact with the back of the nasopharynx to close that region off. We have some pharyngeal tonsils and tubule tonsils in the area. Another name for pharyngeal are the adenoids. These become inflamed when we are fighting off like a rhinovirus, or even can be inflamed during allergies, make it difficult for air to make its way down through the nasopharynx. People can have chronic or persistent issues with these and may have them surgically removed if it's constantly restricting the airway. Another feature is the opening of the pharyngotympanic tube, or the eustachian tube, or the auditory tube. So 3 different names for the same thing. This tube helps to drain and equalize pressure within the middle ear, and it does drain and open into the lateral walls of the nasopharynx. So we experience the opening and expansion of those tubes when we go to higher altitude or drop down to lower altitude, right? That's trying to equalize pressure within the middle ear cavity. The oropharynx is associated with the oral cavity. It's a passageway for food, drink, but also air. It's lined with stratified squamous epithelium. There needs to be many, many layers of epithelial cells in this location because it's subject to abrasion, right? Food that we take in is constantly making contact with the cells in this area. They're being sloughed off. We cannot have one layer of cells present. We would be bleeding out the back of our throat. We have palatine tonsils located with the soft palate, lingual tonsils associated with the tongue, right, standing guard against infection. The laryngopharynx associated with the larynx or the voice box here, also lined with stratified squamous epithelium. And this is a very important transitionary point for food and air. The epiglottis is the flap associated with the larynx, and this routes the food down into the esophagus, and it prevents any food from getting into the trachea. So say we have food in our mouth and we swallow, that's going to press the epiglottis down, and it closes off the larynx and the trachea so that food slips into the esophagus here. Moving to the lower respiratory tract, this includes the larynx, trachea, bronchi, bronchioles, and alveoli. It's separated into a conducting zone and respiratory zone. So with the conducting, these are just the tubes that transport gases to and from the alveoli. the air sacs of the lungs where the gas exchange actually takes place. So this is including these larger structures, the larynx, trachea, bronchi, bronchioles. Bronchioles are just the smaller tubes. When we get to the respiratory zone, this is the true site of gas exchange. That respiratory zone begins at the respiratory bronchioles, as being labeled here. Those feed into the alveolar sac due to an alveolar duct, and then each of these little spheres are the alveoli, the air sacs of the lungs. They're composed of simple squamous epithelium. That's where the diffusion of oxygen and carbon dioxide gas occurs between the air and the blood nearby. The larynx, or the voice box, is composed mostly of cartilage. It is anchored to the hyoid bone, that U-shaped bone, superior neck region. It's continuous with the trachea, so the larynx is just the superior aspect of the windpipe. And it really routes the air and food into the correct location. And all due to the epiglottis, like I mentioned earlier, that flap right here. So when we swallow food and drink, it folds down, it closes off the trachea to make sure that nothing gets down into the airway. Sometimes that doesn't go as planned, right? And we kind of have that coughing fit that we go into. And that's due to very sensitive receptors within that area to really make sure nothing makes its way down into the lungs. We also see the vocal cords being labeled here as well. So as air makes its way into the larynx and down through the trachea, we produce our speech, right? We have our own unique voice due to those vocal cords within. Here's a couple different views of the larynx. As I mentioned, it's mostly cartilage, so all of the blue is representing cartilage tissue. There's distinct regions which make it up. In particular, I want you to be considering the thyroid cartilage, this shield-shaped region. The thyroid gland sits atop this, hence the name. The laryngeal prominence, or the Adam's apple, is the midline of that. In males, the presence of testosterone enlarges the larynx, will even make that laryngeal prominence be shown through the skin, right? We typically only see an Adam's apple in men due to that. And it's responsible for creating a deeper voice that men have. Below that, we have the cricoid cartilage, a ring-shaped region, and that leads to the tracheal cartilages, which are C-shaped regions of cartilage. Within, we have a couple different vocal cords. We consider some to be true, others are false or vestibular fold. The true vocal cords are ligaments that produce sound as air passes through them. The glottis is the opening between the vocal cords. We don't really have a great view of that. I'll show you it on the next page. But those false cords, or those vestibular folds, help to close the glottis during swallowing. Here we have some endoscope images showing us the glottis, the vestibular folds, and the true vocal cords. So the glottis is just the opening between the vocal cords that allow air to pass into the trachea. So here's the opening, the glottis. Here's the glottis closed off due to the vocal cords, the true cords coming together. We have the vestibular folds, or the false vocal cords, more lateral to the glottis, but are there to help control the opening and closing of the glottis. So of course the true vocal cords are producing sound as air passes by, but it can also serve as a sphincter to prevent airflow into the trachea. This becomes really present when we conduct the Vas Lavas maneuver. So when we want to, pick up something really heavy, or we're kind of straining to defecate or urinate, we will close off our vocal cords, and that will increase the intra-abdominal pressure within. So you can sit where you are right now and do that, right? Pretend you're about to lift up a couch, right? You kind of hold your breath and you close off the trachea with your vocal cords to conduct that maneuver. Laryngitis refers to inflammation of the vocal cords. I don't know if you've ever experienced that before or not. I didn't till I think it was last year. I truly lost my voice. People will say like, oh yeah, I can't talk, but they're like talking to you. If you have true laryngitis, you can barely make a sound I even had to cancel class. I couldn't go in and lecture. I really had inflamed my vocal cords for some reason, some virus, something like that, and I could barely make a sound at all. For the trachea, this is the windpipe. It's actually only a 4-inch long tube. I think people tend to think it's much longer than it is. It's about 3/4 inch in diameter, and it consists of C-shaped cartilaginous rings. It terminates at the carina, which then branches into left and right primary or main bronchi. The mucosa within our trachea, so the mucosa lining the lumen, is very sensitive to any particles that may get in that area. It's going to cause violent coughing if something does make its way down, right? So if you get into a severe coughing fit due to something passing down in here, your body is working really, really hard to get that out and make sure it does not get down further into the lungs. Here's a cross-sectional view of the trachea. So we see the C-shaped cartilaginous ring here. This is hyaline cartilage. Then we get to the submucosa, being the connective tissue area. There's a lot of seromucous glands within, producing a ridiculous amount of mucus to help entrap any particles that get down into the trachea. And then the mucosa itself is our pseudostratified ciliated columnar epithelium. The esophagus is being shown posterior here. So these are closely connected structures. And you do see that it's a C-shaped cartilaginous ring. It's not a perfect circle. And this is really important because we don't want to have a rigid structure here between the trachea and the esophagus, right? Especially because sometimes we take a really big bite, right? And we swallow a big chunk of food. We need to allow the esophagus to expand quite a lot, and the absence of cartilage here assists with that. We do have a muscle found between these areas called the trachealis. It's a smooth muscle within there, involuntary, but it does contract and really help with coughing to expel mucus that's within the trachea. So I always love to emphasize tissue type because it's really important for understanding anatomy and the physiology of these distinct areas. So we have pseudostratified ciliated columnar epithelium lining our nasal cavity, nasopharynx, trachea, and our large bronchi. So remember that there's a lot of goblet cells associated with this tissue, producing a lot of mucus, which is really important for any tract-like system in our body to trap debris, trap any foreign substance, or to provide, an ease of movement. The cilia for this tissue type is very important for moving, sweeping that mucus trapped debris up and out of the airway. We're constantly swallowing the mucus that's brought up our airway, or we may cough it out, sneeze it out, right? But the cilia in particular are responsible for that movement of it up and out of the tract. Individuals that have smoked for a long period of time or have been exposed to really harsh chemicals in the air, their cilia can be diminished or destroyed, and it makes it very difficult for that mucus to come up and out of the respiratory tract. So they may have what we call smoker's cough. They need to cough very violently, very aggressively to get the mucus out of there because the cilia have been destroyed. With even severe cases, this whole epithelial layer could be replaced with fibrous connective tissue. And that really diminishes the function. That's going to leave these individuals very vulnerable to infection due to the lack of the epithelium. For tracheal obstructions, this is when something is blocking off the trachea. Odds are something is lodged right here underneath the epiglottis, blocking off that opening so air cannot get down into the larynx. It's not passing by the vocal cords, it's not getting into the trachea, and that individual cannot breathe. A very scary situation, right? If someone has a true tracheal obstruction, if they're truly choking, this is a life-threatening situation. One of the scariest things is that this individual cannot speak if they are choking. Air can't get passed through the vocal cords, right? They're not going to be able to produce sound. So the universal sign for choking is to cross your hands over and wrap around your neck and say, I can't speak, I can't breathe, I am truly choking. Okay, so if someone is coughing, gagging, being loud and dramatic and saying, I'm okay, they're fine, right? They're not choking if they're speaking. And I have some family members that are very scared of choking, very fearful of this, but they have the total wrong idea of what choking actually is. So I always tell my young nieces, if someone's making a lot of noise, it's okay. You don't need to be scared of that. It's when they're not making noise is when you really have to be concerned. If you're ever in this situation and you need to save someone's life because they're choking, you need to conduct the Heimlich maneuver. You need to put your hands underneath the ribs and forcefully press on the abdomen, increase the intra-abdominal pressure, and hopefully pop out whatever has lodged into this area right here. For a young child, a baby, you need to flip them upside down and pat them on the back to try to do the same idea. You're not going to be able to really conduct the Heimlich maneuver on them. You're going to have to pat quite forcefully as well. You don't want to be gentle about this. You need to get that out of their airway as fast as possible. And then something they have on the market now, they tend to advertise it quite a bit, is a plunger-like apparatus, a de-choker. So you put this over a person's mouth, you plunge it down, the air does not go into the lungs, it passes out on the side, and then you pull it. You're going to pull on the handle right here, and that just helps to suck out whatever could be trapped in the area. We actually ended up buying, my husband and I bought one of these last Christmas. It was like advertised to us on Facebook, and I'm like, I am buying it because I would hate myself if someone choked in my presence and I said, nah, I'm not going to buy, that $50 life-saving object. So, not to pressure anyone, but it might be a good idea to have one on hand because you never know what could happen. The conducting zone of the respiratory system represents a upside down tree. It's consisting of bronchi, bronchioles, tubes in which air travels on its way to the lungs. So I like this image here. You can clearly see how it looks like an upside down tree, trachea being the trunk, and then there's 23 orders of branching that takes place after that as air makes its way to the alveoli. So there's a left and a right primary bronchus. The right side is a little shorter, wider, more vertical, more prone to obstruction. Then we have lobar or secondary bronchi. These supply the lobes of the lung. There's 3 lobes, superior, middle, and inferior on the right side versus on the left. There's only a superior and inferior, or 2 lobes on the left, and that's due to the heart. So we have a cardiac notch right here. The heart kind of accommodates that space, making the left a little smaller than the right. So each lobar bronchi supplies each lobe. Then it branches into segmental or tertiary bronchi. 10 on the right, 8 on the left. Each of those bronchi supplies a functionally independent segment, the bronchopulmonary segments. So 10 on the right, 8 on the left. The right side is larger, more functional as well. Then these bronchi form into bronchioles, smaller tubes, only 1 millimeter in diameter, and they supply the lobules of the lung. The tissue composition is going to change. There's no longer going to be any cartilage supporting these tubes, but there is a lot of elastic, so they have the ability to stretch and recoil. They consist of simple ciliated cuboidal epithelium. They have well-developed smooth muscle, so they can constrict and dilate, provide resistance to air passage. And this branches into 50 to 80 terminal bronchioles, and this is the termination, the ending point of the conducting zone. So each lobe of the lung divides into those bronchopulmonary segments I referenced on the previous page, and these are independent functional units of the lung. 10 on the right, 8 on the left. Right? Again, the right side is a little larger, more functional. It has 3 lobes versus the left only has 2. So that's why we're seeing a difference in number here. Each segment is served by its own artery, vein, and segmental or tertiary bronchus. These segments are separated by connective tissue septa, right? So they're isolated, they're independent, If one segment is diseased, it can be removed or even can be transplanted. So these are very important, functionally independent segments. The lobules itself are the smallest subdivisions that are visible to the naked eye and are served by each of their own bronchioles. So these lobules are the smaller components found within each segment. So here we're seeing the terminal bronchioles and the respiratory bronchioles. And remember, the terminology being used here, we're saying terminal bronchiole because this is the end or the termination of the conducting zone. The terminal bronchiole is going to feed into 2 or more respiratory bronchioles, and this is the beginning of the respiratory zone or the site of respiratory gas exchange. The respiratory bronchioles feed into alveolar ducts, so still being kind of like tube-like structures here, feeding into an alveolar sac containing many alveoli. So each little sphere is an alveolus. These are the true air sacs of the lungs. They contain a respiratory membrane where gas exchange is taking place. So it looks like a cluster of grapes, right, on a vine. So each of the spheres, each grape being an alveolus, then when we think of that whole cluster, we can say it's an alveolar sac, right? But there's, an abundance of these alveoli, and the air needs to be conducted, through that whole bronchial tree, the terminal bronchiole, to get it down to this respiratory zone. For the alveoli to function in gas exchange, there needs to be an adequate blood supply, right? So there's an extensive network of capillaries, pulmonary capillaries that are surrounding the alveoli so that we can make contact between the air and the blood and really allow for that gas exchange to take place. Some other features that you'll notice from this image is that the terminal and respiratory bronchioles have these bands of smooth muscle around them, and that's really going to play a role in regulating the flow of air to the different regions of the lungs, really controlling how much air is getting down to these alveoli. So if the smooth muscle contracts, that's going to constrict the lumen, right, and kind of constrict and restrict the amount of air passing through and vice versa. So there is regulation that takes place here. And we also see these yellow fibers, which are elastic fibers that surround the alveoli to allow for adequate stretch, but also recoil, right? So as we inhale, air going down through our bronchial tree, stretching and filling these alveoli, and then we exhale, right? And they're going to recoil and reduce in size. So the elasticity here is very important in allowing for adequate function. We don't want any deterioration of this elastic fibers because that really will cause deficient function here. When we look at the alveoli under the microscope, we're looking at a slice of the alveolar sac. So it can be hard to understand when you're looking at this histology picture that we're looking at spheres, right? Because we are taking a 3-dimensional object and looking at just a 2D slice of it. But it is composed of simple squamous epithelium. Very, very thin layer of tissue that's excellent for diffusion. Excellent for the diffusion of oxygen and carbon dioxide gas between the blood and the air, right? So very important that, you realize it's this tissue type. We're not going to find cuboidal here, columnar. We're not going to find connective tissue. That is not an adequate tissue for gas exchange. So this is one of the most classic, statements in anatomy and physiology is that the alveoli are composed of simple squamous epithelium. When we look at the cells making up the simple squamous epithelium, there are some variations. So type 1 alveolar cells, these are, the most abundant, kind of the typical making up this tissue layer. Thin, broad, squamous cells, allowing for that rapid gas exchange. So here we're looking at one alveolus as being cut in half, but you got to keep in mind it's a sphere. And then you see these capillaries surrounding it. So where the alveolar cells and the capillary wall are coming in contact, that forms the true, respiratory membrane, the area that, exchange is actually taking place. With the type 2 alveolar cells, these are more cuboidal-like, so a little bit fatter, and these aren't playing really a role in gas exchange here. They're actually responsible for secreting surfactant and other antimicrobial proteins. So surfactant is really important at decreasing surface tension within the alveolus, making sure that it's nice and expanded and opened up and allowing for adequate gas exchange. And I'll talk more about that in a few pages. There's also alveolar macrophages, or dust cells. So these are being shown as kind of purpley blue color here. Well, they're macrophages, so very good at engulfing debris or engulfing any things that gets down to the alveoli, keeping this environment very sterile and clean. And these are very numerous, right? The air we are inhaling all the time has all kinds of stuff in it. So we need to have a healthy supply of immune cells here, providing protection. And we have nearly 2 million dead macrophages per hour that are carried up by cilia to the throat to be swallowed or to be coughed out. So these are just constantly, being produced, but also dying and always providing protection for us. So next we'll talk a little bit more about the gross anatomy of the lungs, some important anatomical features here. First, starting off, thinking of the superior aspect here of the lung, we call that the apex, or kind of the sharp tip. That's just deep to the clavicle or to the collarbone. While the inferior aspect here is more broad, so we call that the base, and that rests right atop the diaphragm. Always remember the diaphragm, it's a muscular sheet. It separates the thoracic and the abdominal cavity, and it has all to do with the mechanics of breathing, so it's very important muscle. With the right lung, we see here that there are 1, 2, 3 lobes, while the left has only 2, or we could say a superior lobe and an inferior lobe. And those lobes are separated by an oblique fissure, oblique running at a diagonal, that's why it's using that name, right? And then the left has this cardiac notch, literally an indentation to allow for the heart to kind of take up that space. So that cardiac notch is unique to the left lung. Then on the right, we have a superior, middle, and inferior. And since there are 3 lobes, there are going to be 2 fissures. A horizontal fissure, more horizontal, more left and right, but also an oblique fissure running more at a diagonal. And keep in mind that a fissure is a deep, narrow cavity. So these lobes are quite, individual or quite separate from one another. These fissures are separating them. So you could stick your hand up into this fissure and kind of pull apart the different lobes. When we do the fetal pig dissection, you can really kind of see how, okay, these are quite distinct lobes. Right? So make sure you realize these major differences here between the left and right side. Now to talk about the pleura, which is a thin, double-layered serous membrane surrounding the lungs. So a similar, concept as the pericardium and the peritoneum, right? These are serous membranes that are providing protection around vital organs. We're looking at a cross-section here of the thoracic cavity, right? We have vertebrae, here would be anterior, the heart, and the lungs on either side. So there are 2 layers making up this sac. We have the parietal pleura, being the outer membrane found on the thoracic wall, found on the superior face of the diaphragm, around the heart, between the lungs, so really lining any, outer surface, while the visceral pleura is on the inner, or on the surface of the lung itself. It's the inner membrane here. So as the lungs expand, we take a really deep breath, we can make contact with the visceral and the parietal pleura, but there's really no friction there because there's some pleural fluid in between, helping to really lubricate both of those membranes and making sure that these structures are just gliding across one another. Right, so that's really the function, providing protection, but also making it a frictionless environment by lubricating between those 2 layers. So pleurisy is when there's inflammation of the pleura, And there could be a variety of reasons for this to occur. Maybe there's an infection, maybe the membrane's just not being synthesized adequately, not enough pleural fluid is being formed, right? There's a variety of reasons, but ultimately, there's inflammation, the surfaces are rough, and when they come in contact with one another, it creates friction and it creates a lot of pain. And it's a very uncomfortable situation for someone. A similar issue could occur called pleural effusion, and this is when there's abnormal accumulation of fluid in that pleural cavity. Right? So there's too much fluid between the visceral and the parietal layer. This can cause a lot of back pressure on the lung. It's not going to allow it to expand fully, and people are going to feel very short of breath and feel very uncomfortable. And this is actually something that commonly occurs with left-sided heart failure, right? That's when the left side of the heart is not pumping adequately, causes a backup of pressure and fluid in the lungs, so much so that the blood within those pulmonary capillaries is forced out and actually goes into the lung tissue and can accumulate like this. So, typically these are going to go hand in hand, pleural effusion and left-sided heart failure. And taking a brief look at the pulmonary circulation, hopefully this is kind of a review in reference to the pathway of blood through the heart. So blood that's on the right side of the heart, on the right ventricle, is pumped through the pulmonary trunk, which then feeds into left and right pulmonary arteries. And this is being shown blue here because keep in mind that this is oxygen poor blood, or we could say deoxygenated blood. It needs to be taken to the lungs to become oxygenated. The pulmonary arteries are going to branch into lobar arteries, 2 on the left, 3 on the right for the respective number of lobes. Lobar arteries are going to branch into smaller and smaller arteries, eventually becoming those pulmonary capillaries that are wrapped around the alveoli, allowing for the gas exchange to take place. And then pulmonary veins are then returning oxygen-rich blood or oxygenated blood back to the left side of the heart, so it can then be pumped through the systemic circulation to distribute that oxygen throughout the body. So you just got to remember that with the pulmonary circulation, arteries and veins still implying the direction in which blood is moving, right? Arteries away from the heart, veins returning to the heart, but the level of oxygenation is reversed compared to like the systemic circulation and compared to other body locations. Then for the bronchial circulation, this is kind of the separate circulation that's providing oxygenated blood and nutrient-rich blood to the lung tissue, right? So the pulmonary circulation really just being involved with like gas exchange, oxygenating all of the blood, versus the bronchial circulation, we're talking about nourishing the lung tissue. Same concept when we think of heart. The heart is a pump and then its own coronary circulation, right? It's still a tissue, it's still an organ, it needs to be supplied just like every other aspect of the body, okay? So the bronchial arteries arise from the aorta. They enter into the lungs at the root of the hilum, so kind of being the inner indentation of the lungs, that medial middle aspect there, and then it's going to branch and just supply all that lung tissue just like we would see anywhere else. So this is part of the systemic circulation, right? And then bronchial veins are going to collect deoxygenated blood and just return it to the general blood circulation. So the bronchioles are innervated by the parasympathetic and sympathetic motor fibers or motor division, as well as visceral sensory fibers. So it's always sending, a level of sensory information to the brain, and then for the motor output, that's controlled by both branches of the autonomic nervous system. So the function here is going to be antagonistic to one another, right? Parasympathetic fibers are going to cause bronchoconstriction, right? So they're going to, constrict the airway, going to cause that smooth muscle to contract, really reduce the lumen diameter here, and really kind of restrict the amount of air moving through the airway. In contrast, the sympathetic fibers are going to cause bronchodilation. They're going to increase that lumen diameter, and they're going to allow more air to pass through the airways. And this should make sense to you because when we're in a sympathetic state, we're in that fight or flight response, right? We're really jacked up. We got a lot of adrenaline running through the body. We need to run away or fight for our life. We need more air going to our lungs. We need more oxygenation in our blood so that we can supply our skeletal muscles for whatever we need to do to, save our life. Versus, parasympathetic, resting and digesting, we don't need a lot of air going to our lungs. So we're just getting kind of a normal supply, right? And that lumen diameter is just reduced at that point. It's not at its, fully dilated state. So now we're going to talk about the mechanics of breathing. And this is really dependent upon pressure and volume differences between atmospheric pressure and respiratory pressures. So atmospheric pressure, that's the pressure exerted on us by air in our atmosphere. Right? So the air that's surrounding us right now has different gases, and it exerts a certain amount of pressure. And that pressure varies depending upon where we're found. So if we're right at sea level, standing right next to the ocean, that's sea level, that's 1 atmosphere of pressure, or about 760 millimeters of mercury. If we're at higher altitudes, the atmospheric pressure reduces, the amount of gases in the air reduces, the amount of oxygen in the air reduces, so it can be more difficult to breathe at higher altitudes, if you're at the top of a mountain. And then if you, go underwater, you're scuba diving or whatnot, you're below sea level, that pressure is going to increase significantly. So atmospheric pressure directly influences our mechanics of breathing. And then for our respiratory pressures, we're thinking about, the different chambers within the lungs, within the thoracic cavity, the air that's in there, and the pressure that it exerts. So for intrapulmonary pressure, we're talking about the pressure within the alveoli, pressure within the lungs itself, intrapulmonary. It fluctuates with breathing, right? It's going to change depending on if we're inhaling or we're exhaling, but it's always eventually going to equalize with atmospheric pressure. Those two pressures and their pressure differences is really what's influencing breathing. Intrapleural pressure, now we're talking about the pressure within the pleural cavity. So you have to pay very close attention to the term, right? You really think about which pressure we're talking about. This always has a negative pressure in healthy lungs, and it acts like a vacuum, like a sucking force that keeps the lungs inflated, keeps them within the thoracic cavity adequately. All right. So on this visual, we're seeing 0 for intrapulmonary pressure, and that just means that it's equalized with atmospheric pressure. While the intrapleural pressure being about -4, that's that negative pressure, again, that sucking force keeping the lungs inflated. We can quickly see a problem occur if there's a lung collapse or atelectasis, and this is due to anything that causes the intrapleural pressure to rise. Right? If air is getting into the pleural space or that pleural cavity, that's going to diminish that negative pressure. Air and pressure will accumulate here, and that's going to push on the lungs and cause it to collapse or to deflate. Right? So pneumothorax, that's when air enters the pleural cavity, and that's what can lead to atelectasis or to a lung collapse. But also could be influenced by pleural effusion, so fluid accumulating in the cavity as well. So with the transpulmonary pressure, we're just talking about the difference between the intrapulmonary and the intrapleural pressure. Again, this should be a negative pressure. We're just saying trans, what's the difference across those two chambers? And it's correlating with what I was just talking about. The intrapleural pressure needs to be negative, that transpulmonary pressure needs to be negative, difference between the two. If there's no difference, the lungs are not going to function adequately. There needs to be that negative sucking force keeping the lungs inflated like that. and that allows them to expand when we take a deep breath, and it's also responsible for allowing recoil. Here are some visuals of the changes that could take place. So again, pneumothorax, referring to air that's accumulating in the pleural cavity. And there could be different causes. Maybe someone is stabbed. There's a knife wound that punctures into the lungs, punctures through that parietal pleura. So air is being introduced between the parietal and visceral layer of the pleura. Okay. Or, maybe that visceral pleura ruptures for some reason. This can occur spontaneously, infection, other issues. But regardless, pneumothorax, there's air accumulating here. If air accumulates, the pressure is going to increase. So it's no longer going to be that -4, no longer be that negative pressure. It's going to accumulate, and that's going to push on the lung, and it's going to cause it to collapse. It's not going to allow it to, fill the thoracic cavity, and it's not going to allow it to go through gas exchange. So that true collapse that's occurring in that bottom image, we call that atelectasis. So when we talk about pulmonary ventilation, the ventilation part is like the movement in and out of the lungs, inspiration and expiration. So we use ventilation for that. When we say respiration, we're more talking about gas exchange. Okay, so ventilation being inspiration and expiration. It has all to do with the difference between pressure and volumes between the inside and the outside of the lungs. Right? Air in any gas is always going to flow down its pressure gradient from a high pressure or high concentration to a low pressure or low concentration. That's just a natural process that takes place. Things go down their gradient, things go downhill. And something that's very important to understand is Boyle's law. This is a gas law. It states that there's an inverse relationship between pressure and volume of a gas. So if one variable increases, the other decreases no matter what. It's a law, it's how it is, that's just how all gases behave. So if you have an increase in volume, as being shown in this image, this container here, the volume or the space is increasing, that's going to decrease the pressure. Those gas molecules are going to have more room to move around. They're not as jammed packed together. They're not going to exert as much pressure, right? So volume increasing, pressure decreasing. Well, if we reduce the volume, right, we compress this chamber here, a decrease in volume is going to cause an increase in pressure. The gas doesn't have as much space to move around. There's going to be more collisions against the wall of that container, and that exerts pressure on that system. The same concept is true when we think of the lungs and we think about the thoracic cavity and think about the volume and pressure changes that are taking place in the lungs. And the diaphragm is the muscle that has all to do with ventilation and has all to do with altering the lung volume. So it's the prime mover of pulmonary ventilation. At rest, it has a very, parachute shape, as I like to describe. It's kind of jutted into the thoracic cavity, and it will change shape, change the volume in the lungs during inspiration. We also have external intercostal muscles that will assist with ventilation. So this is rib meat, right? Literally the muscles between our ribs, costal meaning ribs. So there's external and internal muscles here. So there's kind of, two groups associated with the ribs. So during inspiration, when we inhale, the diaphragm contracts. It goes from that parachute shape to more of a flattened, kind of pulled down structure. Also, the external intercostals will contract, and that is going to increase the lung volume. It's going to increase the space in which the lungs can expand. That increase in volume is going to cause a decrease in pressure. So now there's less pressure inside the lungs than outside the lungs. So air is just going to flow in, going down its pressure gradient from high to low. Right? Air will come in, go through the bronchial tree, get down to the alveoli, do its thing. Then when we're ready to exhale, it's a passive process. The diaphragm relaxes, right, takes on its parachute shape. the lung volume is decreasing, so the pressure is increasing, it's accumulating. That pressure wants to flow from high to low, so we exhale and we release the air from the lungs. So just going down, it's pressure gradient. So quiet expiration is passive. It doesn't require energy. It's just due to the recoil of the diaphragm, recoil of the lungs, just kind of that release that lets the air out. Versus forced expiration, so if I want to really blow out as much air as possible, that's an active process. I have to activate additional muscles to make that happen. So the internal intercostal muscles, our abdominal muscles, we're going to really contract our core to try to expel as much air as possible with that movement. So there are different factors that influence pulmonary ventilation. The three main things being airway resistance, alveolar surface tension, and lung compliance. So we'll take a look at each of those. So for airway resistance, really it's coming down to the diameter of the lumen within the bronchi and within the bronchioles. And airway resistance really isn't an issue for individuals with healthy lungs. Right? We have pretty large diameter airways, air is not thick, it has a low viscosity, and there's extensive branching, so there's many routes in which air can take, so the resistance is fairly low. But if you're someone that has, say, asthma, or you have COPD, any kind of issue like that, your airway resistance may be increased compared to others. Individuals with asthma, they either have an allergen or an irritant, even something like cold air can kind of trigger an attack. It causes bronchoconstriction, so the bronchioles the muscle in there is going to contract, reduce the diameter, but also cause an accumulation of inflammatory chemicals and fluid and mucus. It really causes a lot of resistance in the airway for those individuals. It makes it really hard for them to breathe. Right, so there can be different things, irritants and allergens, that trigger it for that person. So then alveolar surface tension is an important factor influencing pulmonary ventilation, and it has to do with surface tension and the production of surfactant. So surface tension is present at any gas-liquid boundary. So surface tension is present at the respiratory membrane, and it's present within the inside of the alveolar wall. There's a thin film of water there, and water molecules are really attracted to one another, and it creates a force or surface tension that kind of wants to collapse the alveolus or collapse the sphere. So you see down below with this image, normal alveoli nice and open and expanded, and then when there's increase in surface tension, there's some collapse of those alveoli or collapse of the sphere. So, outlining that whole sphere being water, it wants to come together, it wants to kind of collapse. Well, the body produces surfactant, and this is a detergent-like substance produced by those type 2 alveolar cells, and it functions to decrease alveolar surface tension. It kind of inhibits that attractive force between the water molecules, and it allows the alveolus to expand really adequately, be nice and open, and reduce those inward forces produced by the water molecules. Okay, so it's very important that you understand this is decreasing alveolar surface tension, allowing the alveolus to expand adequately. This is an important substance that's produced toward the end of gestation. So, right toward the end, right before a woman is to give birth to her baby. And premature babies can lack adequate amounts of surfactant and have a difficulty breathing because there's not enough surfactant there and their alveoli are literally collapsed. They don't have the ability to open up appropriately, and often these premature babies actually need some synthetic surfactant to get the airways fully opened up and to make sure that adequate gas exchange is taking place. So then lung compliance being the last major factor influencing pulmonary ventilation. And this, in general describes the ease with which the lungs can expand. And this is going to be determined by the elasticity of the lung tissue. How healthy are the elastic fibers within the alveoli? It's influenced by alveolar surface tension, and then distensibility, being the ability to distend or extend the thoracic cavity, stretching it when we take a deep breath. Whenever fibrosis occurs, the accumulation of non-elastic scar tissue, this can decrease lung compliance, and both internally and, externally. So say, you get in a bad accident and you have maybe like road rash around your chest or a severe injury to the chest and it's replaced by scar tissue. Well, that external tissue may not be able to expand as well. That could even restrict, your ability to ventilate. Or if there's fibrosis internally, that is also can really influence the lung compliance as well. And then more on, an alveolar scale, emphysema is a type of COPD or chronic pulmonary disease that's due to the deterioration of the elastic fibers surrounding the alveoli. So these individuals, they don't have really an issue with inhaling. The air goes in, but it doesn't have that natural recoil of the elasticity, so the exhale is reduced. Not as much air is leaving, and actually the air becomes trapped within the lungs, and it can rupture the alveolar walls, cause the alveoli to become very large, and these people will be barrel-chested because air is literally trapped inside, right? So the air went in, but not very good at coming out because there's no adequate recoil. So then for lung volumes and capacities, these lung volumes can be measured using a spirometer. So it could be a simple one like this, which I'm sure everyone's seen in like a doctor's office before, or a more fancy electronic spirometer can measure the volume, the amount of air going in and out of your lungs. And then from there can calculate different capacities, which really provide a lot of information on a person's respiratory status and can be very diagnostic as well. So taking a look at this graph here, we have millimeters representing the volume of air moving in and out of the lungs. And starting off this kind of lighter blue region, this is representing the tidal volume. So the amount of in and air moving in and out with each normal breath, or just during like quiet breathing. So you sitting right now, listening to this video lecture, the amount of air you're breathing in and out, that's your tidal volume. And it's usually right around like a half a liter. Then the inspiratory reserve volume, that represents the maximum amount of air you can take in beyond the tidal volume, beyond just your normal breath. So me asking you right now, take the deepest inhale that you possibly can. Well, that, volume of air is your inspiratory reserve volume. Expiratory reserve volume, that's just the maximum amount of air you can exhale beyond a normal tidal volume. And then in green, residual volume, that just represents air that will always be in your lungs. We cannot, exhale all of the air. There's always going to be some that remains. And then from that, we can calculate capacities. So if you, obtain these 3 volumes from an individual, you can get a lot of information from that. We can calculate a functional residual capacity, inspiratory capacity, vital capacity, or a total lung capacity. So here's kind of a table just representing those different measurements, the normal values for a male versus a female, and here being a description of that. I absolutely want you to know a description for these volumes. You don't have to stress about knowing the average volume. I don't really care that you know that. It's definitely good to know that tidal volume is usually around 500 milliliters or about a half a liter, but you don't have to memorize all of these numbers, but you definitely need to know, what these volumes represent. And then for these respiratory capacities, you don't need to stress about these as much. If you're going into the respiratory therapy program, obviously you're going to have to know that in great detail. but I'm not as worried that you know every single one of these here. Although the name kind of makes sense, right? And really it's just calculations based off of these volumes up above. So one major benefit that spirometry provides is the ability to distinguish between obstructive pulmonary diseases and restrictive pulmonary diseases. So for obstructive, it's involving some increased airway resistance, so things like bronchitis, emphysema, asthma. There's going to be distinct, capacities that are reduced or increased that really provide a key indication of some disease or disorder. And then restrictive, really more involving reduced total lung capacity. So tuberculosis and fibrosis being a couple examples of that. So the ability of the lungs to expand is limited or restricted. Then down below here, talking a little bit more about something called the forced expiratory volume. So I didn't mention that one on the previous page, but the forced expiratory volume, or the FEV1, is representing the volume of air exhaled during your first second of exhaling. And in healthy lungs, we should be exhaling around 80% of that forced vital capacity within 1 second. We should be able to remove that air very quickly, again, about 80% in that first second. If that volume is decreased or increased, that really provides the indication of the type of disease that a person may or may not have. So for alveolar ventilation, there's a few terms that we want to consider. So for minute ventilation, we're talking about the total amount of air that flows into and out of the respiratory tract per minute. And for healthy people, just during normal, quiet breathing, like we're all doing right now, that normal breathing rate is about 12 breaths per minute and about 6 liters being moved in and out per minute. Versus the alveolar ventilation rate, this is the amount of air that flows into and out of the alveoli per minute. So it's minute ventilation, but it subtracts the air wasted within the dead space. So the dead space just being, all the bronchioles, all the passageways, or the alveoli that are not being involved with gas exchange, right? There's a significant amount of air there that's not really, transferring oxygen and carbon dioxide. It's just, within the bronchi or within the bronchioles. So the alveolar ventilation rate is a better index of effective ventilation because that dead space is removed, right? And in healthy people, that's around 4.2 liters per minute. So 1.8 liters or around 2 liters is just air kind of in a dead space, not really doing anything. When we think of gas exchange, this involves both external and internal respiration. External respiration, talking about that transfer in the lungs. Internal respiration, talking about the transfer at the tissue cells, right? And the passage of oxygen and carbon dioxide is different for each type. So oxygen gas diffusing from the lungs to the blood in external respiration, CO2 diffusing from the blood to the lungs, and then it's going to be vice versa for the internal respiration. So the diffusion of respiratory gases is all dependent on the partial pressure of those gases. And you can just think of that as basically the concentration of those gases. So gases behave different than a liquid or a solid, right? And they exert a certain amount of pressure, all kind of dependent upon, how much of that gas is present. So it really is just saying kind of a concentration. Gases are just naturally going to fuse from a high partial pressure or a high concentration to a low concentration, right? They go down their pressure gradient. That's just a natural thing that takes place. Diffusion is passive. It's not really requiring energy for that movement, right? So these gases are going to diffuse. This table below is representing the gases and their partial pressure in the atmosphere at sea level. So here's about approximate percentages, the pressures that they exert. There's a total pressure when we think about air as a whole, and then each individual pressure exerted by each individual gas is the partial pressure. And there's going to be a difference between the atmosphere and the alveoli, and it's that difference between the two which drives gas exchange. So taking a look at that external respiration and thinking about the partial pressure of oxygen and carbon dioxide gas, the visual down below, here are the concentrations for the air within the alveoli compared to, the blood of the pulmonary circuit associated with the alveoli. We see with the inspired air that the partial pressure of the oxygen is greater than what we find in the alveoli, so about 160 millimeters of mercury versus 104. So oxygen is going to move from the air to the blood, going down that pressure gradient. Then with the carbon dioxide, the inspired air, that partial pressure is quite low in comparison to what we see within the alveoli. So again, just going down that pressure gradient, carbon dioxide is going to move from the blood to the air, just following that natural diffusion process. Now focusing on internal respiration, gas exchange at the tissues, and then looking at this visual here, we have blood leaving the lungs, entering the tissue capillaries, thinking about those concentrations. So we have, a lot of oxygen gas, some amount of CO2 there as well, versus down at the tissues, we're seeing the oxygen and carbon dioxide levels, then blood leaving the tissues and entering the lungs. So seeing the change taking place throughout the circuit here. So at the tissues, when blood is coming to those capillaries and making contact with the tissue fluid or interstitial fluid, oxygen is going to move from the blood to the tissues down that pressure gradient, down that concentration gradient. Then CO2 is going to move in, right? But it's the same concept, the whole time, moving down the gradient, but it all depends on, where the concentration is higher and where it's lower. That's what's influencing the movement. So there are different things that really influence this external respiration. So one being the partial pressure gradients and gas solubility, two being the thickness and surface area of the respiratory membrane, and then three, ventilation perfusion coupling. So for our first, variable here, just talking about how there's a steep gradient that's established for oxygen between the blood and the lungs, which really drives that movement of oxygen in. So the venous blood, the oxygen partial pressure is only 40 versus in the alveoli being 104. That's quite a gradient. It's really influencing that oxygen uptake. While the partial pressure gradient for CO2 is less steep. There's only a difference of about 5 millimeters of mercury. So CO2 still has the ability to diffuse, pretty much equal quantities with oxygen because its solubility is actually increased. It's about 20 times more soluble in the alveolar fluid than oxygen. It has the ability to dissolve much more easily. So it doesn't need as much of a steep gradient because of that solubility factor. Then the thickness and surface area of the respiratory membrane. Well, the respiratory membrane is normally very, very thin, and that allows for very rapid diffusion. If there's any thickness of that respiratory membrane, such as what occurs during inflammation and infection, that can drastically reduce the gas exchange that takes place just because it's really affecting that thickness, really slowing down diffusion. And then ventilation perfusion coupling, representing kind of the matching of alveolar ventilation with pulmonary blood perfusion. So matching, gas exchange and blood movement, making sure that that's optimal for adequate diffusion. Ventilation perfusion coupling is just as the name implies. It's the matching of alveolar ventilation, or the gas reaching the alveoli, with pulmonary blood perfusion, blood reaching the alveoli. We want to couple this. We want to match it perfectly for optimal gas exchange. So there are auto-regulatory mechanisms in place to synchronize or to couple these two critical components. And this mechanism is very unique to the lungs in particular because the function of the lungs is to oxygenate the blood, right? But elsewhere in the body, the mechanism is going to be exactly the opposite. Because out in the tissues, we're trying to oxygenate the tissues, right? We're trying to give off oxygen. So the mechanisms are opposite because the function is opposite. So the partial pressure of oxygen gas is what controls perfusion due to the change in arterial diameter. So wherever alveolar oxygen is high, right, that's a desired area if it's heavily oxygenated. The air is high in oxygen. So the arterioles in that area are going to dilate. More blood is going to flow to that oxygen-rich site so it can pick up the oxygen. The opposite, so if there's an area in the alveoli where the oxygen is quite poor, like not a lot of air has got to that area, then the blood has no desire to go there. Arterioles will constrict. Not as much blood flow going over there. It's oxygen poor, not a good place to be going. Then partial pressure of carbon dioxide gas is what's going to control ventilation. And it does so by changing bronchial diameter, right? Constricting or dilating the bronchioles is what's going to influence an increase or decrease in airflow. This allows for the elimination of carbon dioxide more rapidly. And that's a very critical component, right? That's kind of the main priority of our body is to eliminate CO2 so that it does not affect the acid-base balance of our blood. For oxygen transport in our blood, there's two ways that it's transported. Mainly, 98.5% is bound to hemoglobin. There's a small amount that can be dissolved in blood plasma, but, in comparison, it needs that hemoglobin for transport. Each hemoglobin molecule contains 4 polypeptide chains. There's alpha chains, there's beta chains, and each of those chains contains a heme group. That heme group contains an iron atom. Iron is what is responsible for binding to oxygen gas molecules. Each oxygen gas is an O2 molecule, and 4 of those molecules can be bound to each hemoglobin molecule. So in red, 1, 2, 3, 4 oxygen gas molecules bound to 1 hemoglobin molecule. Oxyhemoglobin is a name we use when oxygen is bound versus deoxyhemoglobin when oxygen has been released. One important thing to realize is that venous blood is not completely deoxygenated. Even though I've used that term throughout the semester, it's really just to, be a little dramatic and really emphasize the difference between arterial and venous blood. Because in reality, venous blood is oxygen poor. It has less oxygen in comparison to the arterial blood. So with the arterial blood, the hemoglobin is 98% saturated. Venous blood, it's 75% saturated. So there's still a lot of oxygen present in the venous blood. That establishes a venous reserve. A substantial amount of oxygen still available in the bloodstream if needed. Say the respiratory system is not functioning appropriately, right? We don't drop dead instantly. We still have oxygen within our body, within our blood. For the loading and unloading of oxygen gas to hemoglobin, there's different factors that influence this process. There's a change in the three-dimensional shape of hemoglobin, and there's also a change in the affinity or the binding strength of oxygen to the hemoglobin. There's a lot more biochemistry here involved in really understanding the idea and what goes on with the molecule itself. But there are different factors that influence the affinity, the binding strength, and influence the three-dimensional shape. This is a protein and needs to have that very specific functional 3D shape to it. So if there's any change in partial pressure of oxygen or CO2, temperature, blood pH, and then a molecule called BPG, that can really affect the loading and unloading. But what this image down below illustrates is that when oxygen is bound, oxyhemoglobin versus deoxyhemoglobin, there is a distinct change in the shape and structure of the molecule. And it just really assists with the pickup and the drop off at different parts of the body. Carbon dioxide transport in the blood is found in 3 forms. Around 7% of it is just dissolved in the plasma as CO2. Around 20% bound to hemoglobin. It attaches to the globin chain, not the heme group, so that there's no competition between the CO2 and the oxygen gas. 70% of the CO2 transport is as bicarbonate ions within the blood plasma. So HCO3 negative, that is bicarb. I want you to be able to recognize that molecule as bicarbonate. It's very important because it really influences the pH of our blood. Remember that our blood has a very, very narrow range for pH, 7.35 to 7.45. So it's very important for maintaining blood pH. And of course, CO2 also a very important factor in that. So this chemical reaction is represented below. This reaction can occur within our plasma itself, but our red blood cells really catalyze this reaction due to the presence of the enzyme called carbonic anhydrase. So that really allows for the conversion of CO2 into bicarbonate. So when CO2 binds with water, it forms carbonic acid, which then dissociates into bicarb and hydrogen ions. So bicarb is really important, as a transport molecule for the CO2. But one thing that happens here is the hydrogen ions are released into the plasma. And hydrogen ions are what directly impact pH. Hydrogen ions, a lot of them is going to make the blood more acidic versus a lack of them will make the blood more alkaline. So we say that CO2 is acidic because it can lead to the release of these hydrogen ions. Luckily, we have a bicarbonate buffer system in the body that I'll talk a lot more about in the acid-base chapter to really regulate and balance things out. But for now, I just want you to realize that most of the CO2 is transported as bicarbonate, and CO2 plays an important role in our blood pH. Hypoxia refers to inadequate oxygen delivery to the tissues. There's a lot of different causes as to why this may occur. Somebody could be anemic. There could be ischemia, so blockage or impaired blood flow to a certain area. That's usually what's going on with a heart attack. Maybe there's poison in the body that's not allowing the cells to utilize oxygen, not allowing the mitochondria to go through that cellular respiration process. Maybe there's something wrong with the respiratory system. And then another one could be carbon monoxide poisoning. So if you're in a closed off area where, say, like an engine is running or there's some kind of combustion reaction taking place and there's not a constant supply of oxygen coming in, that carbon monoxide will accumulate in concentration and can quickly be deadly to the body. And the reason being is that carbon monoxide has a 200 times greater affinity or binding strength to hemoglobin than oxygen. So over time, the hemoglobin becomes completely occupied by the carbon monoxide gas, tightly bound to it. So there's no place for the oxygen to bind and quickly leads to hypoxia and quickly causes the body to shut down. So very dangerous. There's no odor, there's no, visual detection of carbon monoxide. This is a very dangerous poison to our body. We consider neural controls of respiration. It can be regulated by higher brain centers, so our thinking brain, right? We can control our breathing. But then there's more involuntary reflexive things that control respiration, like our chemoreceptors and then our brainstem structures, the medulla and pons. For the medulla, there's a ventral respiratory group and a dorsal respiratory group. For the ventral, the more anterior component, this is the rhythm generating and integrative center for breathing. It sets eupnea. It sets a normal respiratory rate, around 12 to 15 breaths per minute. This is due to the innervation of the phrenic nerve, also have the intercostal nerves innervating the diaphragm, really setting this pace. Versus the dorsal respiratory group is more involved with modifying the respiratory rhythm due to input from peripheral stretch receptors and chemoreceptors. So when we change our body activity, right, maybe we start to jog or start to do some physical exercise, this dorsal group is going to be stimulated and it's going to accommodate for that change in body activity. Then our pons has a pontine respiratory center. This really helps to smooth out transitions between inspiration and expiration, modifies, our breathing rhythms during vocalization, sleep, exercise. So like my pontine respiratory center is really functioning right now. I'm trying my best to speak as well as I can and breathe at a somewhat normal pace. This is a nice visual here representing the different factors that influence breathing rate and depth. So chemical factors are a huge one. These are going to stimulate our chemoreceptors. We have peripheral and central ones, very sensitive to CO2 levels, O2, hydrogen ions, things of that nature. That's going to act on those respiratory centers within the medulla and pons. We have higher brain centers, our cerebral cortex, our thinking brain, and our emotions can act on this. Stretch receptors in the lungs, irritant receptors in the lungs can influence that. Receptors from our muscles and joints when we have a change in physical activity. Of all the factors mentioned on the previous page, chemical factors are the most important of all. It's the carbon dioxide levels in our blood that are the most potent, most closely controlled chemical factor that influence our breathing rate and our breathing depth. So it's not about obtaining oxygen, it's about removing carbon dioxide waste. And one of the major reasons is because CO2 quickly influences the pH of our blood, right? Quickly dissociates into bicarb and hydrogen ions. So it's very, very closely regulated. We increase our activity, we're increasing the amount of energy that we're using, and we're making more CO2, so we need to get rid of that. We need to eliminate it. Yes, it's important to obtain oxygen, but you have to keep in mind that we do have that huge oxygen venous reserve. Right? Within the venous system, it's still 75% saturated with oxygen. So we have quite a lot of it on backup if needed. It's more important to eliminate carbon dioxide. As I mentioned, our blood pH has to be maintained within that narrow range of 7.35 to 7.45, and our carbon dioxide levels quickly influence that narrow range. When we have a lot of CO2, it's going to push this reaction forward. It's going to combine with water, form carbonic acid, dissociate into hydrogen ions and bicarb. An increase in hydrogen ions decreases the pH, makes the blood acidic. So hypercapnia, an increase in CO2, can cause acidosis. That will quickly stimulate deep, rapid breathing so we get rid of CO2 out of our body to help to restore our blood pH. The opposite would be hypocapnia, where we have a decreased level of CO2 in the blood. This is going to cause the reverse reaction. If we don't have enough of this CO2 component here on the left, it will shift this reaction to the left. Bicarb will soak up those hydrogen ions, start to dissociate CO2, and that will cause our blood to become more basic or more alkaline. This is going to stimulate slow, shallow breathing. It's going to cause us to hold on to more CO2, retain CO2 in our body. So it's going to quickly affect our respiratory rate. Could even lead to apnea, stopping of breathing or breathing sensation until that blood pH is restored. In one situation in which this could occur is when someone hyperventilates. So maybe you're having an anxiety attack or something like that. If you breathe really, really rapidly, you're getting rid of a lot of CO2 all at once, and that will quickly really influence our blood pH. Other factors that are going to influence the breathing rate and depth, so higher brain centers, whether it be our limbic system, our emotions affecting it, but even cortical controls, right? Like we can hold our breath if we want to go underwater or hold our breath when something stinks, something like that. Pulmonary irritant reflexes, we have very sensitive receptors in the bronchioles that will cause bronchoconstriction in response to irritants, dust, any chemical fumes, right? Our airways will quickly close up to try to prevent any damage. And then the inflation reflex, stretch receptors in our pleura and airways are stimulated when we take a deep, deep breath. And that sends inhibitory signals to the medulla to end inhalation and allow expiration. Basically, just a protective mechanism in place so we don't overexpand our lungs. Okay, so we've reached the end of chapter 22, the respiratory system. Feel free to reach out if you have any questions.